Thank you all for coming. My name is Scott Jensen, Senator from Carver County, Senate District 47. As Will Rogers said, even if you're on the right track, you'll get run over if you just sit there. And that's why we're here before you today. Today, we're not going to nibble at the edges. We want to do something substantial in healthcare. And so today, you're going to hear about several initiatives. You're going to hear about a direct primary care bill that will talk about how to focus on the relationship between provider and patient. You're going to hear about facility fees and transparency and how that will impact on the cost of care. You'll also hear about how can we motivate people, patients, to participate in shared savings and shopping. We're also going to talk about how important the protection of patients are in regards to pre-existing conditions, and you'll hear about that. And then lastly, I think a real signature piece of our efforts this session will be on trying to deal with the supply chain in regards to pharmaceuticals. It's an awkward supply chain, and it's not intuitive. It was perhaps before 1965, but once Medicare and Medicaid came in, within a few years after that, we had the advent of pharmacy benefit managers, and they impact profoundly on how the business of selling medicines to patients all takes place. So we'll talk about that. Having said that, I'd like to turn it over to Senator Benson and Senator Kiffmeyer to speak about direct primary care. Senator Kiffmeyer.
Thank you very much, Scott. Glad to be with you today, and I'm so excited about the direct primary care bill. One of the things you hear so much from people, they want to be connected with their doctor. They want to have that relationship. But many times today, our system, which has many pieces to it, is a roadblock to that whole important relationship. So what is direct primary care? This is where it allows you to establish a specific relationship with a doctor and you, a connection point where they are connected to you and you are connected to them, where you're able to have on a monthly basis and on an annual basis an arrangement that allows you to get to see your doctor when you need to. You get to have services when you need them. You get to make phone calls or texts because you have a relationship. They have your records. They have other things that are so very important to you. And as I've been at other places, I serve on the Rural Health Advisory Task Force from Governor Dayton. And on those, and I've talked about this a little bit throughout the state, and there's just been a gleam in people's eyes of saying, yes, that's what I want. I want that relationship. And direct primary care bill is the vehicle and the tool and the statutory framework that allows that to happen. You would pay a low, flat monthly fee. You'd have unlimited visits, same-day appointments, relaxed visits, a little bit more time, because now you have a relationship and an investing in you and the time that you have with that doctor. Less paperwork, less bureaucracy, and that's better care right there. Technology-enabled health, Skype, texting, email, Facebook, FaceTime, there are so many ways that you can relate to a physician today, and especially when you have that contracted direct primary care relationship that facilitates that. This is an exciting opportunity to have more personal doctor-patient relationships, and all it takes is a little bit of a statutory change, and we're able to go forward with that for everybody in Minnesota, and especially for preventive sore throats, the smaller kinds of care things that mean a big deal to how you function in your day-to-day life for you, your children, and your whole family. Thank you.
Thank you. Well, I'm excited about the direct primary care bill because I've had really good relationships with essentially two doctors my whole life, the one I had growing up and the one I have now for my family. And what that has taught me as a mom, by the time I get to my doctor, he knows me enough that he trusts when I say 3 days of a fever, this is what's going on. He knows that it's time for him to make a decision. And vice versa, when he says this isn't something to worry about, come back in a couple of days, or better, give me a call and let's talk through it. And that kind of personal service is, I think, something that Minnesotans appreciate. We're also seeing growing evidence that a long-term primary care relationship lowers the cost of chronic disease care and improves health overall. And so I think it's important for us as the Senate, as the legislature, and as people who make public policy to re-emphasize the importance of a close relationship between a care provider and their patient so we can build trust and improve health for Minnesotans long term. Thank you. And now I think Senator Draheim is going to talk to us about more consumer engagement.
Thank you. Good morning. I'm Senator Rich Dreheim. My goal has been to attack healthcare to make patients first. And for me, it's about transparency and cost. So on the transparency side, facility fees is one area that we worked on where we want to know what it's going to cost us to go to a facility. And then the other piece of that is the billing statement that we receive from our caregivers. Can we have it so we can understand it? Is it clear, concise? Is it timely? So we're working on that. And then the last piece that I have today is the patient's right to shop. So I want to incentivize patients to shop around, even out of network, on their health care procedures and be able to take a percentage of that savings and put it into account to use for future healthcare costs like deductibles, co-insurance, or maybe even premiums down the road. So thank you. Senator Abler's up next.
Well, thank you, Senator Dreheim. Senator Jim Abler and I have had the privilege of serving here for 20 years and been a provider for 40. And there have been a few press conferences on healthcare in that time. You might have heard them. And so this was popular for a while. It actually didn't work quite so well in the last election, so this one's kind of done. This one worked a little better, free healthcare for all. But healthcare is not free, and it's not true that this is, but it works. The postcards you should have sent out to be accurate in this world would look like this. And because it's that complex, it's deep, and some of the ideas you're hearing today are actually simple in their concept and complicated in how they work, but that's the kind of results we have to have. Well, one postcard I can tell you that's true is that we are absolutely committed to protecting people with pre-existing conditions. And if you, in Minnesota, if you have had a pre-existing condition and you've had coverage and want it, you can still get it. Under all of our proposals and all of our thinking, this is true. Just to remind people, though, most individuals in Minnesota already have coverage. If you have Medicare, Medicaid, Minnesota Care, if you have a group plan, except for a few groups, you're already covered already. So don't be subject to the fear of it. But we are absolutely watching your back to make sure that nobody is left behind and they all can get the care that they need when they need it at the right spot at a price they can actually afford. Thank you.
And lastly, I'd like to explore a little bit about the pharmacy benefit manager bill that we have. This is going to focus on affordability, cost, and access. Specifically, this bill will license pharmacy benefit managers. It will help regulate the way they do business. And you might be wondering, okay, what exactly is a pharmacy benefit manager? Originally, they started out in the late 1960s as someone that would process, a company that would process prescriptions, and that was really what they did. But the scope of what they do expanded. And by the 1980s, some of the pharmacy benefit managers were starting to look at creating tiered formularies. It was another 10 or 20 years later where instead of doing tiered formularies, you'd have your pharmacy benefit managers actually excluding drugs. They say, no, this group isn't going to be allowed on our formulary. Within a short period of time after that, they started to say, we're going to be making decisions on the move. Well, that was a huge problem for patients because they would sign up for an insurance plan and they would look at the formulary coverage. And within 3 to 6 months after starting that plan, they would find out that the formulary had changed. And all of a sudden, the medicines that they'd been on for years that had worked were no longer on it. And it wasn't necessarily that it was an expensive trade name drug that they were on. They might have been on a comparably priced agent, but they were having to switch. So pharmacy benefit managers have changed the game. You might wonder, well, why do insurance companies use them? Because business of medicines is big business. 50% of all prescription drugs in the world are consumed by U.S. citizens. 85% of all narcotics consumed in the world are consumed by U.S. citizens. Medicines is a big piece. Over the last 2 decades, we've seen inpatient care drop from 34% down to about 17%. But during that time, we've seen the cost of medicines go from less than 10% to closing in on 30% if you add them up all along the way in the doctor's office, in the pharmacies, in the hospitals, and things like that. Pharmacy, literally, is a parasite with an insatiable appetite. And if we don't step in, we're not going to be able to fix it. So let's go back. What would the supply chain look like to a 10-year-old? The drug would be made. It would be shipped to someone who would then give it to a patient. So, if I could, drug is made, distributed to the pharmacy. What's happened? The PBM entered the scene. Now, did the PBM enter the scene because we wanted to make things convoluted? No, they had a service to provide. And so we need to help the pharmacy benefit managers provide that service in an arena of transparency. We can't have a PBM make a contract with a manufacturer for an inflated price so that they can pass that inflated price on to an independent pharmacy and then get a rebate back for the 50% of the inflated price. And it isn't just about rebates. There are rebate administration fees. There are rebate everything. There's coupons. We see pharmacy benefit managers moving upstream and downstream to capitalize on dollars. And that needs to happen in a transparent environment. Independent pharmacies are often remarkably disadvantaged because PBMs, pharmacy benefit managers, can drive business to pharmacies that they've purchased. They can drive business to specialty pharmacies that they own and that are mail order only. The breadth of what a PBM does is expansive. And we need to appreciate what they bring to the table. But we also need to say this has to be done in an open fashion. There's no question formulary changes impact adversely on patients. Another thing that Senator Benson and I have worked hard on is the whole concept of synchronization. Oftentimes, Betty Lou might be getting 2 of her medicines on January 15th, 2 of her medicines on February 4th, and 3 of them on February 27th. And they come to me and say, is there any way I can get them all at the same time? So this bill calls for allowing synchronization 1 time a year without an adverse cost to the patient or to the pharmacy. Right now, that's not in the situation. You may have heard of gag clauses. We know there are situations where a patient will go to a pharmacy for a 5-day course of amoxicillin, and they'll put their card on the table and say, here's my insurance card. And the pharmacist says, oh, okay, that's $40. If the patient had asked one critical question and said, if I pay cash for this, what would this cost? It may well be $10. I was in a meeting this morning by the airport, and literally a drug manufacturer representative came to me and said, you know, what you're doing is really important. I went to the pharmacy yesterday to get an antibiotic, and they said it was $30 with my card. And I just happened to ask, just for giggles, what would it cost if I just paid you out of my purse? And they said, well, then it's only $15. This is happening not just once in a while. I have data's all over. 25% of the time, the copay that you use with your card is greater than the cash basis price. So there's no question we can help pharmacy benefit managers do their work in a more transparent environment. That'll be healthier for all of us. At this point in time, I may have said enough about pharmacy benefit managers. I'd like to have us open up for questions, but I would like to say one other thing. We oftentimes forget what the pharmacist brings to the table. They're not just giving you a bottle of pills. Pharmacists are the ones that oftentimes will have at their fingertips a tablet, if you will, that all they have to do is pop in a couple of clicks, and they've got all your meds there, and it'll pop up any contraindications, any adverse interactions. We don't have that in our doctor's offices. We need to make certain that we're fully embracing all that a pharmacist brings to the team, because it's oftentimes their ability to catch errors or things that hadn't been known. And that's a big part of this bill as well. So thank you, everybody, for being here. We stand for questions. Thank you.
Senator Jensen, can you explain more about how the direct primary care works and about what prevents people from doing this right now, just going directly to a doctor and paying cash or whatever?
I'm going to give you 15 seconds, but I'd like to turn it over to Senator Benson and Senator Kiffmeyer. For me as a primary care doc, what it does is it allows me to get rid of the dollar incentive. So I had a call this morning about 6:30 from a woman who was very embarrassed that she was waking me up at 6:30 in the morning, but I'd already been up for a while. But she said, is there any way I could bring Johnny in for a strep culture at 8 o'clock this morning? I know I don't have an appointment. I said, yeah, go ahead. It would be way easier if I would have known that patient, if I would have had a direct relationship with that patient. This is a patient who comes to our clinic but doesn't see me, sees one of my partners. This is the kind of relationship we want, so people can say, you know what, I don't need to see a doc. I don't need to take your time. I just need a strep screen. And if the strep screen is negative, we'll treat it symptomatically. If strep screen is positive, call in a prescription. We can do those kind of things. That's one thing that happens. The other thing is, then you don't have to worry about freezing Johnny's wart. You know, if Johnny's got a wart, you know, hey, can I get in and I just want you to freeze Johnny's wart. There's a lot more simple stuff. The insurance company would be taken out of the equation. The middleman would be gone. It would just be the old-fashioned way, patient, doctor.
How would the doctor bill?
$75 a month, generally billed by quarters.
Okay, so is there anything that prevents people from doing that now? Or do you have to go through, or when you go to a clinic, do you say, well, if you don't, you say you don't have insurance, are they going to get turned away?
I think Senator Benson can do a better job answering that question than I can. Senator Benson.
What we're actually doing with direct primary care is making sure that physicians don't have to be an insurance company in order to offer health care under a contract. So that's the most significant piece. It frees up physicians to do this, reminds them that it's okay to have this relationship. We don't want to, undermine the importance of insurance. You need that for catastrophic care, or if you have a difficult, complex chronic disease or multiple issues, you're going to need coverage for that. But we had a doctor come in. She practices in St. Cloud. She does this. Did she have 300 clients?
Yep.
And patients. The way she talked about, they'd send her a text message and she knew them well enough that she could say, oh, this one might be overreacting a little bit. Let me give her some feedback and follow up on symptoms. The other one, she'd say, yeah, let's get you into the office and take a look at this. So the doctor knew the patients well enough that it reconnected the care model that I think primary care providers really want, patients need. And for our long-term healthcare system, we're going to need this relationship. Let's think about something unique. At the end of life, or when you're in your most expensive point, let's say you have cancer or something really difficult that you're going through, and you have a relationship with a doctor that you've had for 3, 5, 10 years, and that person says, I don't know that this is the best decision for you. Just because a specialist says you need it, maybe there's an alternative. I know your family and I care deeply about you. What does that do to the care conversation as opposed to let's just continue to see specialists? And so,
But is it cheaper? Because I know insurance companies often negotiate down lower rates. Is this cheaper to do it this way?
Senator Kiffmeyer?
Yes, it is cheaper, Tom. And the main reason is you take that insurance company out of that whole mix. So when you do that, that frees up time and increases a relationship. But then you don't have that middle in between that all has cost. All those middle things have a cost. You remove that, now it's direct from the physician. What a lot of people don't know is sometimes a physician will bill a certain amount of money, but by the time it goes through the insurance company, they end up with a very small portion of that. What we want to do is cut that all out and enable that, all those dollars to go directly to the actual physician and the actual patient and that monthly kind of a thing. The other thing is that, yes, you can do it right now with your out-of-pocket money, anything you want to do. But again, there's the question of the insurance, which is a physician issue. The other thing is you may have a health savings account or a flexible spending account. We want to make it possible that you can use those dollars that are pre-tax dollars to pay for the service without it being called insurance, because you can have that relationship in network or out of network. Have you all noticed sometimes a lot of the changes between physicians are coming because in network, out network, and you always have that. And I feel it's been one of the most disruptive things to the care of a patient and the doctor is this constant changing. Then they have to do more tests. They have to do this and that. This enables you, in a long-term basis, to have that relationship, have that contractual relationship between the physician and you. But whether it's insurance question, we need to answer that, but also the ability to use the flexible spending accounts, health savings accounts, funds, and other things that you already have, and you don't have to go and dip into a separate cash pocket.
So the statute needs to change in order to go around the insurance requirement? Is that what you're saying?
Yes, that's one of the things that needs to happen.
One last comment to Tom Hauser's question. If you just take a 40-year-old patient and a 60-year-old patient, take a 40-year-old patient that maybe comes in for a physical and 2 office visits during the course of the year, and with their physical, they'd like to have a cholesterol, a glucose, a hemoglobin checked, and perhaps an EKG. They will have costs somewhere around $700 or $800. Your total cost of this direct primary care relationship is $900. You also have your 24/7, your medication management, things like that. If you take the 60-year-old patient that has maybe a history of hypertension, type 2 diabetes, and elevated cholesterol, they're going to probably come in 4 or 5 times during the course of the year. And they're also going to have a physical. Their costs, if you just did it on list prices, would be somewhere around $2,000 to $3,000. It'd be $900 just the same. And then if you had a 50-year-old patient that was going through change of life issues and they needed to see a mental health therapist, and you had a primary care clinic that had a mental health therapist, they would be able to see that person as well. And a lot of the dollar things that sort of klutz up the whole thing, they'd be gone. It would just be, what can we do that works best for you? Other questions?
Senator, could you talk a little bit about how you prevent people with pre-existing conditions from being excluded under that direct primary care model?
The direct primary care model needs to be understood as this is care. That's the first step. The second step is the insurance. So I'm going to have Senator Abler speak to that, but we have to make that distinction. We have to transform the conversation. There's care and there's insurance. The first step is let's get you hooked into a relationship, because even if you don't have insurance, if you have a relationship, you may well be able to talk to that direct primary relationship you have and find out that you don't need to go to the emergency room, that we can take care of this right here and that it's relatively straightforward. Or that if you do need an MRI, we could send you here instead of this facility, and instead of spending $3,000 for the MRI, it's $600 for you out of pocket. Senator Abler, would you comment?
Sure. Well, there's a ton of research about how if you have a relationship, you don't spend as much money, somebody who's going to care about you. And so certainly this wouldn't cover hospitalization, but it would cover the contact. And so I'll just be short about that. But it actually works. And actually on behalf of the providers who are being driven from their profession and driven from primary care, they went in there not to do insurance forms, not to spend a lot of time going through authorizations, but to serve people. If you have a cluster of 300 patients, you can happily do that and do it very well. In my clinic, we spend 40% of our money coming in on billing, just so you know. No benefit.
Senator Jensen, you said a lot about that was more negative about pharmacy benefit managers. What are the benefits to the PBMs?
Well, the PBMs do provide significant services in terms of creating a formulary that works for that insurance plan. So if Blue Cross goes out and hires a PBM, they'll help them shape that formulary. That's a big deal. In so doing, they'll help the negotiation process with the manufacturers. That's a big deal. They'll create a streamlined mechanism so that the medications costs that are coming from a hospital or from a clinic are going to one center, one clearinghouse. So in terms of, if you will, processing the prescription, creating a formulary, negotiating prices from the manufacturer, sampling the waters in terms of could we get a biosimilar here instead of buying the trade name drug? Those are the kinds of things that they're being asked to do. And I'm probably shortchanging their job description a little bit. There's probably a couple other things if I look through my notes, in fairness to them. And
the parasite, how does that make them cheaper? You talked about the parasite.
Well, here's an example. If we would, in this bill, does get to the governance and the conduct of their business in regards to, I don't know if you've ever heard of a DIR, it's a direct and an indirect reimbursement that the pharmacies have to pay back to the PBM on a quarterly basis. The pharmacy has no idea what that cost is going to be. They don't know if they're going to get a bill for $10,000, $15,000, or $25,000. These arbitrary and somewhat capricious clawbacks are astonishing. We need to get that information in front of you so that when you go see the pharmacist, you have an idea, what is the pharmacist really making on this? Because oftentimes you're using that pharmacist's services because you want to support them. You appreciate the service they provide, and yet you're absolutely uncertain of what they're actually getting paid.
And you said the gag order. Does that mean that that pharmacist could not say to me, hey, pal, why don't you ask me how much the cash price is? Is that what you meant by the gag?
Yes. Right now, if the pharmacist initiates a conversation, they'd be violating their contract with the PBM. If the patient asks, what would it cost on a cash basis, then they can answer the question honestly. One last question.
Somewhat related topic, but there was just a loud back and forth in here about pros and cons of recreational marijuana, supporters and advocates of which. Advocates believe that this will take care of a lot of prescription drug costs, recreational marijuana to solve some of their health problems. Is that a non-starter with you?
I think that clearly we cannot blame any discussion or disagreement about marijuana on PBMs. Thank you. Thank you very much for coming.
Senator, Dr. Rutherford, I can wait. Can I ask you a question?
Absolutely.
And this is just